Welcome back to the deep dive. We are jumping right back into our graduate seminar series, Bodies, Systems, and Stories, a critical history of medicine.
And we are really making a jump today.
We really are. If you were with us for Lecture 6, you'll remember we were very much in the domestic sphere. We were talking about folk medicine, women healers, the smell of herbs in the kitchen.
The home is the absolute center of care.
Exactly. But today we're leaving all that behind. We are walking out of the cottage and into the cold, echoing halls of the hospital.
It's a jarring transition, and it's meant to be. We're tackling Lecture 7, The Birth of the Clinic and Diagnostic Technology. And honestly, if you're looking for the moment where medicine stops being an art of comfort and really starts trying to be a science of the body,
this is it.
This is the turning point.
We're zooming in on the early 19th century, right? The Paris School of Medicine, roughly between 1800 and 1850.
That's the time and place. And our mission for this deep dive is pretty specific. We want to analyze that pivotal moment, that shift.
Yeah.
From a doctor listening to a patient's story to a doctor trying to read the patient's body.
From narrative to sign.
Exactly, from narrative to sign. And I want to pause on that for a second because it sounds a little abstract, but it's probably the most practical, most fundamental shift in all of medical history.
It's the difference between a doctor asking, "So tell me about your life," and a doctor asking.
Or does it hurt?
Or not even that, more like, "Let me find the broken part," because that's the feeling I get. We're not just gaining a new tool here. We're fundamentally changing the relationship.
It's a massive trade-off.
Mm-hmm.
And to really get it, you have to remember what we talked about last time, that domestic default.
Right, in Lecture 6.
The patient was the main character.
Yeah.
The healer, who was usually a woman, maybe a neighbor, was there to facilitate the patient's narrative and comfort.
Kitchen physic. It was personal, it was warm, it was all subjective.
It was. Today, we trade the herbal posset for the stethoscope. We are moving from the bedside to the clinical ward. And the central conflict here, really, is how a simple wooden tube accidentally silenced the patient while giving the doctor what looked, for all the world, like superpowers.
The so what here feels huge. You're talking about the birth of the clinical gaze.
That's the term historians and philosophers, especially Michel Foucault, use. And the clinical gaze isn't just looking at someone. It's a very specific way of seeing that turns a person into a case study.
It's like a visual dismantling of the person.
Yes, into a series of organs, tissues, and potential pathologies.
Okay, let's get into it. Slide 1. We're looking at an image of René Laennec. He's holding this, it looks like a wooden baton.
It's a stethoscope, yeah.
And he's superimposed over the Hôpital Necker in Paris. He looks very serious, very formal.
Laennec is definitely our protagonist today, but the setting is just as important. Post-revolutionary Paris. You have to understand, the French Revolution didn't just, decapitate the king. It completely upended the entire institutional structure of France.
So all the old systems were gone.
The universities, the church-run hospitals, the old guilds, they were all either swept away or radically reorganized. It was chaos.
But chaos creates opportunity.
It absolutely does. The state took over the care of the poor, and they created these massive, and I mean massive, public hospitals. And that is the laboratory where modern medicine was invented.
The title of this lecture is From Narrative to Sign.
Yeah.
You said this is an epistemological shift. Let's unpack that term, epistemological, for everyone listening.
Sure. Epistemology is basically the study of knowledge.
Yeah.
It asks, how do we know what we know? What counts as truth? Before this period, medical truth was defined by the patient's voice.
Yeah.
If you said you were in pain, well, that was the truth. After this period, medical truth is defined by what the doctor can find, what he can observe in your body. The truth literally moves from your mouth to your organs.
To really feel the weight of that, we need to look at the before. So slide 2, the old regime of diagnosis, pre-1800.
Right.
I have this mental image of a doctor, maybe in a powdered wig, coming to a wealthy person's house. He sits down at the bedside. And then...
What does he do?
He sits. That's the key. He doesn't stand over you. He sits with you. And he listens. Diagnosis back then relied almost entirely on the history.
The story.
The whole story. The patient would describe their lifestyle, their diet, their work, their bowel movements, their emotional state, their business failures. Everything was relevant.
It sounds like a cross between a medical exam and a confession. It was a biography, really.
Yeah.
The illness was part of the person's life story, not separate from it. And the patient would describe subjective symptoms. They'd say things like, I feel a throbbing in my temples, or I have a deep malaise.
My spirits are low, things you can't measure.
Exactly. Illness was defined by what the patient felt, And the doctor couldn't really challenge that, could he?
How could he? There were no x-rays, no blood tests. If the patient says, I feel a tightness in my chest because I argued with my wife, the doctor has to work with that narrative.
He has to treat the anger as much as the tightness. They were seen as intertwined.
So what about a physical exam? Did he ever, poke or prod the patient?
Very, very little. And this is crucial to understanding the shift. Touching was considered indelicate. It was socially risky.
Right.
I mean, if you're a male doctor and your patient is an upper-class woman, a duchess, you do not ask her to lift her gown so you can press on her stomach. It's undignified. It would break the social hierarchy.
So the doctor is almost like a librarian of symptoms. You tell him a story, and he tries to find a category for it in a book he read.
That's a fantastic analogy. He classifies the narrative, and because of that, the patient holds all the power. They own the story. The old regime was a patronage system. The rich patient paid the doctor to listen respectfully.
But then, as you said, history intervenes. Slide 3 takes us to the Paris school. The revolution happens. The social order is smashed.
And suddenly, the entire medical landscape is unrecognizable. The revolution concentrated the poor in these huge state hospitals. We're talking about places like the Hôtel Dieu or La Salpêtrière.
And these weren't small 10-bed clinics.
Oh, no. We are talking about thousands of patients crammed into enormous open wards, just rows and rows of beds.
The outline calls them disease showcases, which is a pretty grim term.
It's grim, but it's accurate. Because of the sheer volume of humanity, the doctors couldn't possibly treat these people as individuals with unique biographies. It became about processing numbers.
So if you have 5,000 patients,
you stop looking at the person Jean or Marie, and you start spotting patterns across hundreds of bodies. You can walk down a row of 50 beds and see 50 different stages of, say, tuberculosis, all side by side.
This is where that idea of the body as text comes from, isn't it?
It is. The hospital became a library of pathology. The doctors could compare and contrast in a way that the old house call doctor, who might see one case of that a year, never ever could.
So the hospital becomes a factory for medical knowledge, but they needed a new theory, a new way of thinking to make sense of all this data.
You did. And that brings us to slide 4, and a man named Xavier Bichat.
Bichat, the Napoleon of medicine.
A nickname that gives you a sense of both his ego and his impact. He died young, but he completely rewrote the rules of the game.
What was his big idea? What did he change?
Well, before Bichat, people were still thinking in terms of the ancient Greek humors, the 4 fluids, blood, phlegm, yellow bile, black bile. Sickness was a whole body imbalance.
And Bichat said?
He said, no, that's sloppy thinking. It's too vague. He introduced what we call the tissue theory.
Okay, so what does that mean?
He argued that disease isn't some general imbalance floating around your body. It is a specific lesion, a specific problem in a specific tissue. It's not, I am sick all over. It is, the serous membrane of my lung is inflamed.
That sounds incredibly modern. That's exactly how we think today. If I have a pain, I want to know precisely which muscle or which nerve is causing it.
Bichat invented that specificity. But his method for proving it was, well, it was macabre. He's famous for saying, open up a few corpses. You will dissipate at once the darkness that observation alone could not dissipate.
Open up a few corpses, that is blunt.
He was dissecting bodies night and day in the Paris hospitals. And this is the birth of the clinical anatomical method. The logic is simple, if a bit grim.
Go on.
You track the symptoms while the patient is alive. You take detailed notes, coughing, blood, chest pain, pale skin. Then you wait for them to die.
You wait for them to die.
And then you perform an autopsy. You open them up. You find the physical damage, the hole in the lung tissue, for instance. And then you say, aha, the coughing of blood was the sign of the hole in the lung. You correlate the living symptom with the dead tissue.
You match the story from life to the evidence in death.
Yes. But do you see the fundamental problem with that?
Well, yeah, the truth of the illness is only revealed after the patient is already dead.
Precisely. And that's the diagnostic bottleneck, which is our slide 5. It's a fantastic breakthrough for medical science as a whole, but it's completely useless for the living patient who wants to know what's wrong with them now.
So Bichat gives them the math. He tells them the lesion is the truth, but they have no way to see it while the person is still breathing.
Exactly. You're standing on the outside of this opaque box, the human body, trying to guess at the geography inside. It's a massive frustration for these new scientific-minded doctors.
They did try some things, though, right? The outline mentions immediate auscultation,
which is just a fancy formal term for putting your ear directly on the patient's chest.
I can immediately see the problems there.
Oh, it was a mess. First, the social awkwardness we already talked about.
Mhm.
Second, and this is a big one in these hospitals, hygiene.
Mm.
I mean, the patients were the destitute poor. They often had lice, they were unwashed, they were sweating. A respectable physician really did not want to bury his face in that.
And practically speaking, I imagine it just didn't work very well if a patient is obese or if their heartbeat is faint.
You can't hear much of anything specific. Now, a physician named Leopold Auenbrugger had introduced percussion a few decades earlier.
That's tapping on the chest.
Yeah, like you tap a wine cask to hear if it's full or empty. It was a start. It could tell you if there was a lot of fluid in the lungs, for example. But it wasn't precise enough to find those specific tissue lesions that Bichat was obsessed with.
So we have the theory from Bichat, we have the setting of the hospital, but we are missing the crucial tool.
The tool is missing.
Which brings us to slide 6, the moment of invention. And I love this story because it's not some eureka moment in a lab with bubbling beakers. It's just a guy walking through a park.
It's pure serendipity. The year is 1816. René Laennec is walking through the courtyard of the Louvre in Paris, and he sees two children playing with a long wooden beam.
What are they doing?
One kid is at one end of the beam, scratching it with a pin. The other kid has his ear pressed to the far end.
And the sound travels through the wood.
Exactly. The solid medium conducts and amplifies the sound of the scratch far better than the air does. Laennec sees this, and he files it away in the back of his brain.
And then a little while later,
He's confronted with a difficult case.
Yeah.
A young woman who has all the general symptoms of heart disease, but she's somewhat overweight, and because of her age and her gender, placing his ear directly on her chest.
is inadmissible. It would be improper.
It's a total non-starter.
Yeah.
So he's stuck. He can't tap. He can't listen directly. He needs another way. And then he remembers the kids.
He improvises.
He grabs a quire of paper, which is basically just a notebook, rolls it up into a tight cylinder, places one end on her chest, and puts the other end to his ear.
And what did he hear?
He was shocked. He wrote later that he heard the beating of her heart, much more clearly and distinctly than he had ever been able to do by the immediate application of the ear.
And this is it. This is the birth of what he calls mediate auscultation.
Listening through a medium, that little rolled up notebook.
So that brings us to slide 7, the cylinder. Technology intervenes. Laennec goes home for that appointment and immediately starts experimenting. He starts building a wooden tube.
Right. And we have to be clear. When we picture a stethoscope today, we think of the rubber tubing, the binaural earpieces, the metal diaphragm.
The thing you see hanging around a doctor's neck on a TV show?
Exactly. These early ones were nothing like that. They were rigid, monaural, meaning for one ear, and they looked more like little wooden trumpets or batons.
But the physical object itself is less important than what it did psychologically, right?
That's the key point. It created distance. It put a physical object, a buffer, between the doctor and the patient.
And in doing so, it also created objectification.
It did.
Yeah.
Because as soon as you put an instrument between yourself and another person, you are no longer looking at the person. You're looking through them at something else.
You're ignoring the who to find the what.
Precisely. The patient becomes a container for the disease, and the doctor is no longer a comforting presence, but a technician inspecting a machine for a broken part. This is the very beginning of what we can call the technological gaze. The focus shifts from the whole organism to the specific organ.
But, hearing a sound is one thing. Knowing what that sound actually means is something else entirely. Slide 8 talks about seeing with ears.
It's kind of synesthesia, really. Laennec had to teach himself to visualize the inside of the chest based on these bizarre new sounds he was hearing. Scratching, bubbling, whistling.
He called it a non-invasive autopsy. That is such a powerful phrase.
It is. The ability to see death lurking inside a living body. But to do that, he needed a new language. He needed a vocabulary for these sounds.
So how did he build that?
The hard way. He spent years in the wards, listening to a patient, carefully describing the sound he heard in his notes. And then, when the patient inevitably died, he would cut them open to see what anatomical feature had made that specific sound.
He created a glossary.
He created a whole new language that we still use today, words like rails, raunchy, crepitus.
And the cracked pot sound.
The bruit de pot filet. It was a sound he described as being like tapping a metallic pot that has a crack in it. And through his autopsies, Laennec figured out that this very specific sound meant there was a cavity, a literal hole in the lung tissue, almost always from advanced tuberculosis.
Just think about the power dynamic in that moment. The patient hears a wheeze or a gurgle in their own chest. the doctor hears the crackpot sound.
And the doctor knows.
The doctor knows the patient is dying, but the patient is completely oblivious to the meaning of their own body's language.
It creates a professional monopoly on the truth. Your body is talking, but you can no longer understand it. You've become alienated from it. Only the man with the wooden tube and the special Latin vocabulary knows your fate.
This leads us directly to the absolute core of this lecture. Slide 9. Symptom versus sign. This feels like the graduate-level distinction we really need to nail down.
It is the absolute crux of this whole epistemological shift. It's everything. Let's define the terms.
Okay.
A symptom is subjective. It's what the patient reports. I feel breathless. I feel a sharp pain when I breathe in. It's your story.
And a sign.
A sign is objective. It's what the doctor observes, usually with an instrument. Basal crackles on auscultation. A systolic heart murmur. It's the body's data.
And the history of 19th century medicine, then, is the history of the sign defeating the symptom in the hierarchy of truth.
100%. Before Laennec, the symptom was the disease. If you felt pain, the disease was the pain. Now, symptom is just a clue, and it's a potentially unreliable clue. The sign is considered the hard scientific truth.
There's a figure mentioned here, Pierre Louis. He helped formalize this distinction.
Pierre Louis was a contemporary of Laennec, and he was obsessed with statistics and numbers. He's really the one who solidified the idea that, and this is a phrase we need to sit with, the patient is a poor historian.
Wow. Doctors still say that today. The patient is a poor historian.
It starts right here. The idea takes hold that the patient lies, or the patient forgets. The patient exaggerates. The patient is emotional and irrational. But the stethoscope.
The stethoscope doesn't lie.
It's just wood and air. It's objective. So the doctor is trained to trust the instrument more than the person who is speaking to them.
That's a heavy realization. It means that my own testimony about my own body becomes secondary to the investigation.
Your testimony becomes data to be confirmed or denied by the technology. And this leads to the standardization of pathology, which is what's implied in slide 10. Once you rely on signs, you can categorize diseases in a very rigid scientific way.
So tuberculosis isn't just a vague wasting away or consumption anymore.
No, it becomes a specific, trackable progression of acoustic signs that any trained doctor can identify. First, you hear this sound. A few months later, you hear the bruit de Paufilet. It turns the diagnosis into a kind of checklist.
And that allows for a universal taxonomy of disease. A doctor in Paris and a doctor in London can agree on a diagnosis of pericarditis because they're listening for the same mechanical sounds.
Regardless of what the patient is saying or what their life story is, it detaches the disease from the person.
This creates a completely new hierarchy, doesn't it? Which brings us to slide 11, the hierarchy of the senses. If we were to draw this out as a pyramid, what's at the very top?
At the absolute peak, the ultimate arbiter of truth is sight. Specifically, the sight of the autopsy. That's the gold standard.
Okay, and just below that?
Just below that is hearing, but only when it's mediated by the stethoscope.
Yeah.
It's the proxy for sight. It lets you see inside the dark cavity of the chest while the patient is still alive.
They're at the very bottom.
At the very bottom of the pyramid is the voice, the patient's narrative. It is now considered the least reliable, most suspect source of data.
That is a complete 180-degree reversal of the old regime, where the voice was the only thing that mattered.
And it changes the doctor's identity, too. The 18th century doctor was a passive listener. He sat and received the story. The 19th century doctor is an active investigator.
A detective.
He's a detective. And like any good detective, he often views the primary witness, the patient, with a deep sense of suspicion. He's hunting for clues, and sometimes that means ignoring what the victim is shouting about.
And this changes the actual physical ritual of the exam. I'm thinking of slide 12. We've all experienced this. The doctor puts the stethoscope in their ears, they lean in.
And the first thing they say is, shh, or take a deep breath and don't talk.
It's the silencing of the patient. I mean, literally. You are told to be quiet.
The irony is just staggering, isn't it? To hear the body talk, the person must shut up. And this moment introduces the physical rituals that define the modern exam. Palpation, which is touching, percussion, the tapping, and auscultation, the listening.
These are rituals of authority.
They absolutely are. They perform science for the patient. You see, if I just sit and hold your hand and ask how you're feeling, I could be your friend or a priest or a folk healer. But if I systematically tap your chest and listen with a specialized tool,
then you're a professional. You're a scientist.
It clearly distinguishes the MD from the quack in the eyes of the public.
But surely this wasn't welcomed by everyone. I just can't imagine the wealthy elites of Europe were thrilled about being told to shut up and being poked with a wooden stick.
You're right. That brings us to slide 13. Resistance and acceptance.
Yeah.
The poor in the hospitals had no choice. They were the raw material for this new science. But the elite, the paying customers, they pushed back hard.
They felt objectified.
Completely. And there's that great anecdote about Queen Victoria.
Tell us that one.
Even decades after the stethoscope was invented and widely used, she refused to be examined with one. She found it mechanical and impersonal. She was basically saying, I am the Queen of England, not a biological specimen, not a collection of organs.
She was resisting the clinical gaze.
Yes, because it democratized her body. Under the gaze of the stethoscope, her royal lungs sounded just like a peasant's lungs, and she did not like that one bit.
But in the end, she and everyone else lost that battle.
The triumph of science was pretty much inevitable. By the middle of the 19th century, the stethoscope had become the absolute symbol of the medical profession. If a doctor didn't have one, he wasn't seen as a real modern doctor.
So why did patients eventually accept it? Why did we agree to the silence?
It was the trade-off. We accepted the cold, impersonal instrument because it offered something the comforting narrative never could: diagnostic certainty, or at least the promise of it.
So we traded feeling heard for being known.
Beautifully put. We traded intimacy for accuracy. The stethoscope signaled that the doctor was accessing a deeper, more scientific truth about our chances for survival.
And that trajectory, that trade-off, brings us to slide 14. The legacy. The stethoscope wasn't the endpoint. It was just the first domino to fall.
It was the gateway drug to diagnostic technology. You can draw a straight, unbroken line from Laennec's little wooden tube to the X-ray, to the EKG, to the CT scanner, and all the way to the modern MRI machine.
It's a history of placing more and more complex layers of technology between the doctor and the patient.
And with each new layer, the doctor's role shifts even further. The physician evolves from that healer or priest figure
Into a body technician.
a plumber for the biological machine, an interpreter of data.
We hear this exact complaint all the time today, don't we? My doctor spent the entire visit staring at the computer screen, not at me.
That is the modern manifestation of Laennec's tube. The clinical gaze has become the digital gaze. The doctor is looking at data points, at pixels, at lab results, at the signs, often at the expense of the human being sitting right there in the paper gown.
So to bring it all together for our conclusion, slide 15. We've traced this massive, fundamental shift from what was a biographical art to what is now an anatomical science.
We often talk in this course about the Hippocratic triangle, that core relationship between the doctor, the patient, and the illness. In the Perischool era, that triangle got warped. The axis tilted very heavily toward the doctor-illness connection.
Leaving the patient on the sidelines.
Often, yes. But we have to be fair. We have to acknowledge what was gained.
Of course.
Oh, absolutely. The gain was enormous. We stopped guessing and we started knowing. We gained a staggering amount of biological understanding. The reason we can treat tuberculosis today is because they learned how to identify them. The precision of modern medicine, the ability to find a tumor when it's the size of a pea, all of that, starts with Laennec and his tube.
But we also have to acknowledge the loss, the marginalization of the patient's own voice, their own story.
It's the central tension of our medical system to this day. We have gained the world of the body, but we're always at risk of losing the soul of the patient. The challenge for medicine in the 21st century is, can we use the MRI and still listen to the story? Can we have both the sign and the narrative?
That is the big question. But there's one more piece to the story we need to set up. We've talked about how doctors learn to read the body by comparing sounds in the living to autopsies on the dead.
Right. To learn that the cracked pot sound meant a tubercular cavity, Laennec and his colleagues needed to open up thousands of bodies.
And in the early 19th century, getting your hands on that many fresh corpses, well, that wasn't exactly straightforward or legal.
No, it was a dirty, violent, and deeply unethical business. Science needed raw material, and the demand far outstripped the legal supply.
Which sets us up perfectly for our next session. We're moving on to Lecture 8, The Body Snatchers.
It's going to be a grim one.
We'll be covering grave robbing, the infamous Burke and Hare murders in Edinburgh, and the brutal reality of how the bodies of the poor were essentially harvested for the advancement of medical knowledge.
It's essential, though, to understanding the true cost of this new clinical gaze.
It is. So before we sign off, let's leave you, the learner, with a final provocation to think about this week.
Next time you're at the doctor's office, and they interrupt your story to put a stethoscope on your chest or to turn and look at a screen, just ask yourself, are they listening to you or are they listening to your parts? And does the incredible accuracy of the latter make up for the silence of the former?
A fascinating and maybe slightly uncomfortable question to carry with you. Thank you for joining us on this deep dive into the birth of the clinic. We will see you next time for Lecture 8.